Hi, everybody. I'm at that weird age where I can't see up close, so I have to wear my glasses, but then I can't see far away. So I'm still trying to figure that out. So if I look over my glasses, I'm not scowling at you. I'm trying to visualize what is going on. There, that's my disclosure. So I want to thank the American Heart Association, especially Sue, for inviting me to come and speak at this event. When I looked at the speaker group, I seriously thought about ordering a cognitive evaluation for Sue because I was pretty sure she asked the wrong person. So I'm very humbled to be here amidst all of these amazing, amazing stroke doctors. My disclosures, I don't have any financial disclosure. Probably my biggest disclosure, my background is neuro-ICU. I did that for about 12, 15 years, something like that. You lose track after a while. So I did that, and then I became the stroke coordinator. And I was the stroke coordinator for 10 years. During that time, I spent a lot of time with our emergency department staff working on stroke protocols and processes. So I do consider myself bilingual in nursing. I am going to focus on the emergency department portion of the ICH patient, touch very, very briefly on the inpatient portion, but I know there's a speaker this afternoon that's going to hit inpatient more. So just for a show of hands, who is from the emergency department? Who is inpatient? Okay, and where are my stroke coordinators? God love you. All right, my sister-in-law is also a neuro nerd, just like me, and she created this meme, and I said, oh my gosh, I have to have this for my talk. So luckily, she had not copyrighted it yet, and she gave it to me for free. So I love this meme because we have really focused research, data on ischemic strokes. And Dr. Sheth said it perfectly. Up until about 5 years ago, we really weren't looking at how we could help manage the ICH patients. Everything has been ischemic stroke. So I love to see the pendulum switch to those patients who are a smaller volume but a higher mortality to see what we can do to help those patients. Not every patient who comes in with a bleed is going to die, but they are going to have some type of morbidity. So how can we prevent a severe morbidity and maybe get them back home? I love the poster that's out in the hallway about I can't remember the exact words, but early discharge interventions is going to increase the ICH patient going home. I love that. So we've all read the same slide to you. The epidemiology of ICH, bleeding into the brain tissue. It's really hard to find specific hemorrhagic stroke statistics. Everything is kind of lumped in, or you see a lot of ischemic stroke statistics, but the hemorrhagic stroke specific is kind of hard to find. I did find that approximately 8 to 15% of strokes are hemorrhagic, which is in line with what we've been hearing. The fatality rate is 25 to 30% in high-income countries, and as high as 48% in low to middle-income countries. And really, the fatality rate is really reliant on efficient critical care. So what does that mean? What does efficient critical care mean to you guys? It's not a trick question, I promise. Following best practice, and I like to think of that as working as a team. It's not nursing doing their tasks, the providers doing their tasks, rehab doing their task. Everyone is working as a multidisciplinary unit following those best practices to provide efficient care for that patient. Pathophysiology, Dr. Meno just covered this really well. You're going to see the majority in your basal ganglia. The least amount is going to be in your pons or brainstem and in your cerebellum. Your primary injury, remember we have primary and secondary injuries. Your primary injury is going to be due to compression of the brain tissue from the hematoma that is increasing the ICP, and that's where you are really going to start to see those stroke symptoms. The secondary injury is what the inpatient side is really focused on, preventing complications and preventing further decline of neurologic status. Your hematoma expansion is going to occur within the first 3 to 12 hours. And approximately 33% of the time, it occurs within that 3-hour period. So how do we as nurses catch that? A good neuro exam. How many people in here think their nurses do great neuro exams? Okay, all right, we got a few. That's more than I thought. I consider myself to be an expert on neuro exams, but it's only because I have that background, and I'm an ICU nurse, so I think I'm an expert at everything. But if you think out... And yes, I do want to know when they had their last bowel movement. It is important. But when I think about my ED teams, they are a master of everything, but they don't really focus on one thing. So how are we setting our ED staff up to have a solid neuro exam to be able to catch these changes that are probably going to happen while the patient is still in the emergency department? Do we have a standardized neuro assessment the ED can use and trend to identify changes as quickly as possible? And then I want to think about if hematoma expansion is going to happen in the first 3 hours, how many patients arrive within 3 hours of symptom onset? And I think about my patient who had a severe headache, maybe they just felt off or their left side was weak. What did they do? Went to take a nap or went to bed for the night. I'll feel better in the morning. So a lot of times these patients aren't even arriving in that 3-hour period. Or Dr. Royan gave a perfect example, and I have a similar one because it's the bane of all of our existence. The patient who comes in and complains of dizziness or headache, and they come in walking into triage, and you don't have a bed, so you sit them back in the waiting room, and that patient's there for 3 hours while that hematoma is expanding, and no one is watching that patient. So that 3-hour mark is really key to making sure that we have that patient with someone putting their eyes on them a lot. Now, I didn't know that Sue was ordering all of these guideline books for everybody, but it's perfect. You all have the guidelines right in front of you, and I'm going to be referencing the guidelines as we go through this short lecture. We're going to do a case review and walk through what is important to nursing in the guidelines. When I talk to my nurses as a stroke coordinator and I said, well, here are the new clinical practice guidelines, they're like, what? That doesn't mean anything to me. Nursing doesn't think or doesn't feel like the clinical practice guidelines apply to them, but they do. That is how you guys need to take care of your patients. So you have these handy dandy little books on your table, take them back to your teams, and if you want, you can highlight pages in them or tab them or whatever you need to do. So, well, someone was talking, I think it was Dr. Sheth, I went through and put all the page numbers that we're going to be referencing. So get your guidelines in front of you and we're going to go through them. Okay, so the first scenario, we're going to go back and forth between the patient and the guidelines, so it might feel a little clunky, but we'll get there together, don't worry. So it's just another day in your emergency department. It's a Monday morning. The emergency department is already full. There are so many patients that are being boarded, waiting for inpatient discharges. Sound familiar? The triage lobby is quickly filling, and you have no beds to put anyone anywhere. Every hospital in the area is on diversion. EMS calls. You have your little spiel reminding them that you're on diversion and you're not taking any non-critical patients at this time. And they say, we have a stroke alert. So now you have to take this patient. They said the magic words, now you have to take this patient. Okay, continue with your report. See, I told you I was bilingual. We are inbound with a 55-year-old male who was found by his wife with aphasia and right-sided weakness. The wife last saw the patient normal 1 hour ago when she went to the gym. They're reporting a LAMS of 5, blood pressure 200 over 105, heart rate of 100, respiratory rate of 26, and his oxygen is 99% on room air. What do you guys think about this radio report so far? Did it get your attention? Yeah. Which part? Blood pressure? The deficits? What about the LAMS score? We use LAMS in Ohio. If you don't use LAMS, it's just a severity scale. Okay. So they go on to report, per the wife, the patient is non-compliant with his blood pressure medication and takes Eliquis for AFib, although he's currently in sinus rhythm. No known drug allergies, denies taking any illicit drugs, denies any alcohol abuse or consumption, and they will be at your place in 8 minutes. And then you hear the magic words, and the wife is with us. All right, so we're gonna activate a code stroke. We talked to the doctor, we talked to the team. Code stroke is gonna be activated, all hands on deck. This is not a drill. Everyone is in their place, just like a trauma alert. Everyone knows their role. The patient arrives, pit stop in the ambulance bay for a quick stability exam. Go ahead and grab a weight because he is within the TNK, tenectoplase window, thrombolytic window, we'll go thrombolytic. He is within the thrombolytic window, and we're gonna proceed directly to CT. In the scanner, you finish your brief workup. You see a glucose of 200, INR of 1.2, blood pressure 205 over 100, heart rate is 100, normal sinus, respirators are 26, SAT is 99%. Your stroke team does a quick NIH, and he's at 16, and you start your CT, and your door to CT was 5 minutes. Wow. Everyone's giving high fives. You're patting each other on the back. Everyone's so proud of all the awesome work they just did. It's great. I know the lead up is kind of ruined on the topic of this conference. And then you see this, and you hear the stroke team start groaning. And you're afraid to look, but you do, and you see this hemorrhage on the left side. What happens next? Who said everybody leaves? Yes. Everyone's gone. The stroke team says, not it. The ED doc's like, I gotta go find neurosurgery. And all of your nursing friends were like, oh, nope, I don't want any part of this. So you turn around in the control room and everybody is gone. So now it's up to you to run this code ICH. So what are your priorities? And that's what I really want to focus on. It can be really scary to have a hemorrhagic stroke, but there are specific priorities that you need to focus on that will get you through this. Keeping in mind, and this is my stroke coordinator plug, still do your frequent vitals and neuro checks, please. And document them. Thank you. Hit the file button. Okay, the first thing, and as we go through these priorities, keep in mind, this is a parallel process. So we're not gonna do one, and when that's done, we're gonna start on the second. Everything is gonna be going at the same time. The first thing we need to think about is where does the patient need to go? Does your facility have the capabilities to provide this patient the care that they need? If the patient needs neurosurgery, do you have neurosurgery? Do you have neuro ICU expertise or access to it? If you are unable to provide the care that this patient needs, where do they need to go? How quickly can you get them there? And what do you need to have done before you transfer that patient? So in Ohio, we have a lot of med flight companies. What is the barrier to using a medical flight transfer process? Weather. I don't know how it is up here. I assume it's similar to Ohio, but we can fly about 10 days out of the year. And it can be sunny in our north and horrible in Columbus. So we need to figure out what that ground transport's gonna look like, and if it's gonna take 2 hours to get that transport agency to your facility, what can we do in the meantime? What are our priorities to get that patient ready to go to the next level of care? And who is your support and resource? If you're part of a system and you have a spoken hub model, who can you call to ask for help? Who can you call to give recommendations on the best way to care for that patient? Oh, sorry, I forgot to click. Okay, so imaging, this is on page 10 of your guidelines. Your guidelines look a little bit prettier than my snippets here. Do we need additional imaging? So there are very specific guidelines around what imaging we should be obtaining on these patients. If the patient is less than 70 years old and it's a lobar hemorrhage, If the patient is less than 45 years old and it's a deep or posterior fossa hemorrhage, or if the patient is 45 to 70 with no history of hypertension, the recommendation is to also obtain a CTA and possibly a venogram. And what we're looking for are microvascular changes. Does anyone remember the age of our patient? 55, okay. Did he have a history of hypertension? Yes. Yes. So according to the guidelines, we're good with the head CT. That's all we need. Does that mean we shouldn't get a CTA? It's up to your neurosurgery team, but according to the guidelines, all we need to do is get the head CT. If you do go for additional imaging, the CTA, the venogram, keep in mind that patient who has blood in their head is going to be laying flat longer. Make sure that you're monitoring their airway and their level of consciousness as best you can while they're in the scanner, because patients like to code in the scanner, especially neuro patients, and that makes the CT techs really cranky. So make sure you're monitoring the neural status of your patient. Okay, blood pressure management. We've talked a lot about this, and I'm glad that Dr. Royen is the one who summarized all of those trials. I thought about doing it, and it wasn't going to work for me, so I'm glad that she did it. But we're on page 11 now of your guidelines. The gist of this is we want to go quickly but slowly. We want to be steady but fast. We want to treat within 2 hours of onset and obtain our goal within 1 hour. So note the class of recommendation on these levels, 2As. Why don't we have a level 1? It's just not there. There's not enough evidence. There's still research going on, but we have not found the evidence for how quickly we need to get that blood pressure down. What we do know, the best we can come up with is to treat within 2 hours of onset, which also means the last known well, and to reach that target within 1 hour of the first blood pressure medication. And to me, when I first heard that, I was like, an hour? The risk of hematoma expansion in the first 3 hours is 33%. Why are we giving ourselves an hour? But remember, we want to go slow. We don't want huge fluctuations in the blood pressure. So we know we want to treat quickly, but go slowly. And what about our target? Again, note the recommendation levels. These are 2Bs. We just don't have that perfect sweet spot for where our hemorrhagic stroke blood pressure needs to be in order to issue a level 1 recommendation. So what we do know is for mild to moderate ICH, so figure an ICH score of 1 to 3, if they present with a systolic 150 to 220, we want a target of 140. And Dr. Meadows said it best, I'm not going to tell my nurse to keep their blood pressure at 140, because what are you going to do? I'm going to check it once. The first time I get 140, I'm not checking it again. I'm going to let it ride. So if we do a range of 130 to 150, that is a good compromise right around 140. That may be reasonable. And this is kind of like my little plug. Every patient's going to be different. Some patients are going to tolerate 130 to 150. Some patients may need 140 to 160. So I would encourage you guys to look at your patients, work with the medical team, and try to figure out what is the best range for your patient. We do know we do not want to go lower than 130. So we don't want to actively lower the blood pressure to less than 130. And that is like a dance for the bedside nurse, isn't it? How do I get the patient lower, but not too low? For large to severe hemorrhages, so we're thinking ICH of 4 to 5, or if they're going for a surgical decompression, there is zero evidence that lowering the blood pressure is going to be beneficial, which is the complete opposite of what you would think. But there's just no evidence. And my thought on this is we exclude these patients from research. We don't do research on these ICHs of 4 and 5, these severe ICH patients, so we really don't know how to best take care of them. Okay, so to recap, your blood pressure target, we want to go low but not too low. We want to go slow but within 1 hour. Everyone good? So plus you also have to manage your other patients because we're still in the emergency department. You probably have at least 3, maybe 4 other patients. But remember that you're not alone. What is something that you can use at the bedside to help you? The monitor. Use your monitor. Set it for every 5 minutes. Set it to alarm if the pressure is greater than 150 or less than 130. Use your monitor to help you monitor that patient. Make sure you hit file. All right, so we're going back to our patient, our 55-year-old male who has a left basal ganglia hemorrhage. You check the patient's blood pressure and it's 190 over 110. He is a mild to moderate. He's an ICH score of 2. So what is our blood pressure goal? (130 to 150). Okay? So our goal is 130 to 150. He's at 190 over 110. We have the option of labetalol, nicardipine, clevidipine. We use nicardipine mostly at my organization. But you have the option of all 3 of those. Which one are you going to choose? Are you going to go a push or are you going to do a drip? How many people are doing a push? How many people are dripping it? Yeah. And when are you going to recheck the blood pressure? 5 minutes. Love it. So you choose nicardipine. Oops, let me advance here. Okay. You choose nicardipine. You start the drip at 5. Blood pressure recheck in 5 minutes. You're at 160 over 90. So we've gone from 190 down to 160 in 5 minutes. Your monitor is set to cycle every 5 minutes. Ding if less than 130, ding if greater than 150. Are we good on the nicardipine? Yeah? Okay. So you're right, we're going to leave it at 5. We're going to recheck in 15 minutes. We're not actively titrating, so we're going to go for 15 minutes. Your next blood pressure check is 146 over 80. Your nicardipine is still running at 5 milligrams an hour. Your NIH remains 16. He's showing no neuro changes at all. Blood pressure is within target range, but we've now decreased from 190 over 110 to 146 over 80 in 20 minutes. So what are we going to do now? We good on the nicardipine? I chose to decrease it. I decrease it to 2.5 milligrams per hour, and then I'm going to recheck him in 5 minutes, and he's 150 over 80. No neuro changes. I'm good here. We're going to keep checking every 15 minutes, or more frequent if you want. We're going to file our vital signs every time that we check them, and we're going to file them every time we check them. And we're going to just monitor this patient. We can always go up if we need to, but we're good where we are right now. We're not too low, and we're not too high. Next priority, reversal agents. The patient was taking apixaban for AFib. His INR was 1.2. Per the wife, his last dose was last night, which was about 12 hours ago. What is your next step? The wife reports he's mostly compliant with his medications, follows with his PCP regularly. Do we care what the INR is? No. So what's our next step? Luckily, this is on page 12 of your guidelines. We do know that we want to reverse rapidly, and this is a class 1 recommendation. So this is solid. We want to reverse this patient as quickly as possible. How we reverse them is another story, and we heard pros and cons of the I knew I was going to mess that up, andexanet alpha versus PCC. I'm not going to get into that argument at all. You have 2 reversal options. One is a 2A and one is a 2B. What I am going to get into is this awesome algorithm on page 14 and 15 of your guidelines. So we do have a patient who has an ICH and was taking an anticoagulant. Which one was he taking? Apixaban. So he was taking a 10A inhibitor. Next step, we need to figure out when his last dose was. 12 hours ago. Now we're going to figure out what reversal. If we have andexanet alpha available, the recommendation is to use that. If it's not available, PCC. So this algorithm makes your reversal decision extremely easy and guideline-based. We do not have andexanet alpha at our facility, so we would be using PCC. Not pro-con, again, I'm not getting into that fight. What we do want to know is, can we reverse this patient within 60 minutes of arrival? Is it 90 minutes within arrival? And as you go through looking at this process of reversal, I encourage you to break it down each step. We know that the ICH patients don't always come in like this gentleman, where he's a code stroke up front. So how long did it take for your team to activate the alert? How long did it take from the alert to the order? How long from order to administration? And then that's going to give you your overall door to administration. But what is going on in each step of that process that you can look at and potentially improve for that patient? So this was my favorite part of being a stroke coordinator. The stroke core measures are only for ischemic strokes. We don't need to attend your CPIT meetings. Luckily, that is not true. And we have a lot of our measures that really pertain to our hemorrhagic stroke population as well. For example, for our ED patients, CSTK3B getting that ICH score documented within 6 hours of arrival. CSTK4, anticoagulant reversal initiated within 60 minutes of arrival. Now this specific measure is only for the Coumadin patients. But these patients also need to have a dysphagia screen prior to any PO intake, rapid neuroimaging, whether that's a CT, CTA, or the venogram. You have your door to first blood pressure administration, blood pressure medication administration, door to blood pressure control, and then door to admission to a specialized unit. Do you guys have a goal for your ICH patients or your critical care patients of how quickly you want them admitted? What is it? 120. Woo! We do 3 hours. Woo! We are not messing around. No, you are not. And I love you for it. All right, so we're going to review everything we just did. You determined that, you determined the patient did not need to transfer. You guys were perfectly capable of caring for the patient. You ordered the appropriate imaging, which was the head CT. You controlled the blood pressure to within target with Cardine. You administered the reversal agent. Now it's time to call report. So part of your report, you're going to report out the NIH stroke scale. You're going to report out the ICH score. If you're reporting out the NIH stroke scale, make sure you report out what the deficits are, not just the score. Blood pressure is 146/80, we're good with that. Heart rate of 80, respirators are 24, O2 sat's 98%, nicardipine running at 2.5, and the reversal agent was administered 1 hour ago. Don't do that. Tell them what time it was administered. You transport the patient to ICU with his wife. You say, bye-bye. You're going to verify the neurologic findings at the bedside. Probably the best thing that we ever implemented at my organization was the dual neuro assessment at shift change, at transport, at transfer, so that everybody's on the same page. And again, verify that nicardipine drip rate. So what are your ICU priorities? And again, I only have like 1 or 2 slides on these. Don't let the patient die. But how are you going to do that? You have your blood pressure parameters. Make sure that you're maintaining them. Monitor that neurologic status. We all hate hourly neuro exams, especially the patients, but we need to do those to monitor that patient and trend them so we identify any change. Monitor for increased intracranial pressure. Make sure the head of bed's at 30 degrees. Rehab, swallow screens, cognitive evaluations Doesn't matter how normal the patient looks, if they have blood where it's not supposed to be in their head, they need to have a cognitive evaluation. And then social factors. Why wasn't this patient taking his antihypertensives? So this patient, you get case manager involved, social worker, they start digging into it a little bit. The wife tearfully reports that they recently lost their health insurance. The patient only has one more coupon to refill the apixaban, and they were unable to refill the blood pressure medication. So what kind of resources do we need for that patient to make sure that they can get the medication that they need? Inpatient measures, STK1, obviously we're not going to start heparin sub-Q on an ICH patient the day of admission, but we make sure that they get their compression devices. Stroke education needs to be daily and individualized and documented daily and individualized. Did I say individualized? Okay. Daily. Assess for rehab, you've got PT, OT, speech therapy involved. Dysphagia screen prior to PO intake. What about depression? Do we need to monitor for depression in hemorrhagic stroke patients? Most likely going to happen after discharge, but something to keep in mind for while they're admitted as well. All right, you are done. This is your triumphant return back to the emergency department. You make a pit stop at the coffee shack. You get yourself a nice cold brew to celebrate your success with this code ICH patient. You return to the ED. You're like, man, this is not my day. 75-year-old female arrived 3 hours ago complaining of a headache. There were no beds, so she sat in the waiting room, waiting on a normal, regular head CT, which was completed, and the radiologist read it 1 hour ago, or read it, and he just read it. And you have a lobar hemorrhage. So if we think back to our algorithm, I believe it was page 10, what kind of imaging do we need for this patient? Do we need a CTA? She's 75, so she's greater than 70, but she does have a lobar hemorrhage. Does it say CTA? I wrote down no CTA, but I could be wrong. Again, it's that whole visual acuity thing. No? No CTA? Okay. What's that? She's over 70, so we don't need the CTA. What we do need is a code ICH. And luckily, you just went through this. You got this. You know exactly what you need to do. Do you have the services needed to care for this patient at your facility? Blood pressure control. Her blood pressure is currently 140/90. Her ICH score is 1. So what is our target range? (130 to 150). Mild to moderate. Target range is 130 to 150, and she's at 140. And then think about a reversal agent. This patient does not take any anticoagulation, so that's easy. We don't need to do anything there. Next steps for this patient, frequent vital signs and neuro checks. Watch for signs of increased intracranial pressure. What are signs and symptoms of increased intracranial pressure? The first one you think of. Level of consciousness. Is it decreasing? What if the patient suddenly becomes agitated? Is that a change in level of consciousness? I'll never forget, this is the only story I'm going to tell, I swear. I'll never forget, I got report from the ED when I was in the neuro ICU, and this was a patient who, I believe the story was a young patient, and he'd fallen off a bar stool and had a head bleed. Don't know which came first. And so I got report, and they said he's really agitated, so we gave him fentanyl and Versed. And all his pupils are unequal, but we think it's because of the Versed. Okay. So my next call was to the neurosurgery residents, and get your butt down to the ED right now. Agitation is a sign of increased ICP, so don't discount the patient that comes in calm and suddenly they become agitated and trying to hit you. Pain control, nausea control, very important for decreasing ICP. Try to avoid restraints, and sometimes you need to ask the family to leave. If my family's around me when I have a head bleed, please ask them to leave. So in conclusion, your ICH patients are easy to manage in the ED. Is it time-consuming? Sometimes. Is it frantic? Sometimes. But you know what to do. You need to determine the correct care location if they're going to be transferring or admitting to your facility. Obtain blood pressure control. Don't be afraid to start a drip. Don't give labetalol, 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 labetalol. Start that drip. Don't be afraid. You can always turn it off. This patient's going to have a big hospital bill. That bag of nicardipine is not going to matter. Reverse any anticoagulation, but we don't want to reverse antiplatelets. So make sure your docs are not ordering a platelet transfusion. Trend your neurologic assessments. Make sure your ED nurses know what is involved in a neuro assessment and what to look for. And don't freak out. Use your monitor at the bedside and hit file. Any questions? Sorry, that was supposed to be your part.
Got it. If anybody does have questions, please make your way to the microphones in the center.
Jessica's going to ask a hard question.
Well, and I was a CVICU nurse, so my patients never had strokes, right? So take that with a grain of salt. But just kind of curious from a practical standpoint, when someone's on a nicardipine drip or any drip like that, does your hospital have a policy on whether you're doing a invasive versus non-invasive blood pressure cuff? Do you have a policy like after so many hours they need a radial art line or anything like that?
We do not. Does anyone else have that policy? They're on nicardipine for so long they get an arterial line?
No? The non-invasive BP is
Totally fine.
totally fine. Okay, thank you.
I love your passion, by the way.
Who, me?
Yeah.
Oh, thanks. It's the coffee. So this is a cry for help, actually. And those who have just had regulatory surveys may feel my pain. Titration compliance.
Oh.
Yay! Okay, so every survey, it doesn't matter whether it's a stroke survey or a hospital survey, we always are out of compliance for drip titration. Doesn't matter what drip titration. Because our order set is so complicated, we are doomed to fail.
Yeah.
So we're always looking at Q5 minutes. We need exquisite titration in these ICH patients, but we are doomed to fail. So my cry for help is, if anybody is really successful with your titration compliance, would you please share that with the rest of us who all groaned when I said out of compliance with titration? Because our organization needs help. So if anyone in the room is really successful, please let us know, because I need help. Thank you.
We had 6 surveys within like a 4-month period this year, and we had 3 findings around titrations. And we just weren't documenting blood pressures. Remember to file. Anyone have a good titration regimen that they have implemented and have had success? Sorry.
No. And I wanted to ask around the room, we work really hard after we were cited in 2023 for proper care of the hemorrhagic patients. And it really did revolve around documentation of the corresponding blood pressures with what was written in the orders. What we really found was there were conflicts all over the orders. So here's the order, less than 140. Then the note says less than 150. Over here, we've got a range. And so we really had to clean that part up first.
Yeah.
So got that part cleaned up. Now here's my issue. So I finally said to neurosurgery, you need to look at the guidelines, you need to review them. What do you want to utilize for your subarachnoid hemorrhages and for your intracranial hemorrhage? And I provided them with the 2022 guidelines, and I highlighted them. And I also, very clearly highlighted the range. Unfortunately, my ICU said no ranges. It has to be a solid number, which I think leaves our patients, the patient safety, because less than 140 is less than 140. That can be 100 or 139. So that's where I find an issue. So if anybody would like to share their order sets with me, if you have a range, I need to really kind of promote that with our ICU so that I can get that, because I know, and I'm a neuro nurse and ICU nurse by background, and now I'm a stroke coordinator. I know that I work with range my entire career, and we worked within the range, and that's how we titrated our medications, and we did have Q5s going on all the time. And so, again, I'm over here at this table. Come share with me. Thank you.
Who has order sets to share?
Somebody's got a range. Okay, good, okay.
You're going to ask what?
Sarah's got one. And Sarah and I actually go.
Has anyone else had problems implementing a range in their critical care?
Just me.
I'd have to double check ours. I thought ours had a range, but I'm not 100% sure now that you say that.
Okay.
I will check, and if we have them, I'll share them with you.
Thank you.
Yep. Yes.
As far as blood pressure titration, one thing we did when we implemented ICH improvement measures was to make sure that the order had a specific target goal and then a range to maintain afterwards.
Mm-hmm.
And then for our emergency department, we call it a code head bleed instead of a code ICH.
Mm-hmm.
There was titration specific documentation while you were titrating to follow. And then when you're documenting in your EMR, make sure that you have your blood pressure and then you have a titratable drip that's attached to it once you've started it in the MAR in one spot. Whenever there was fallouts, you'd have to go to a different part of the chart the blood pressure, go to a different part of the chart to say what your drip rate is. So we have a stroke flow sheet, but then there's also in the ER just any titratable and ICUs. So you can chart the blood pressure, and then right below it, you can chart the titratable drip that you changed it to. You can do the same thing for all of your infusions, like propofol. If you're titrating to a RAS score, you can have the RAS score there too. So it's all in one line.
A stroke flow sheet?
We have Epic. We created a specific flow sheet that just has the stroke-specific documentation. So your vital signs, your repeat neuro assessments. If you have a thrombectomy, your repeat neurovascular checks, PHQ-9, NIH. So it's all in one area, so you don't have to go to different areas of the chart.
See, I saw everyone furiously writing. What facility are you at?
University Hospital in San Antonio.
University
UT San
Hospital.
Antonio's.
Okay. I'm going to look up your stroke flow sheet on the Epic Library. I'm going to steal it.
Okay.
Shamelessly. Thank you.
Yeah.
I just had a question about my hospital. We're kind of switching. I feel like in the ICUs, we really were pushing people to use PRN, like labetalol and like antihypertensives before going on a nicardipine drip. But it sounds like really the standard from everything that everyone's saying here is we should be starting on a drip to have tighter control and then adding on PRNs on top of that. I just wanted to like get your thoughts on that, and like, is that what your hospital does? Like, do you use nicardipine for saline or?
So technically what my facility does is if the patient arrives and the pressure is greater than 200, start a drip. If it's less than 200, try one dose of labetalol and then go to a drip. That's what my facility does in the ED. Okay. So we don't want to put a patient who doesn't need a drip on a drip, but we also have a very low threshold to start that drip, if that makes sense.
Yeah, that does. Thank
Okay.
you.
Yep.
I'll just add to, we typically do the labetalol while we're getting the nicardipine drip to kind of give that initial dose. Also just want to make a comment regarding that range for the blood pressure. It's really actually quite contrary to the guidelines to say that you need to have a strict number for the blood pressure for ICH. It's really, you're trying to avoid those big peaks and valleys and those vacillations, so that 130 to 150 is a critical component of this. And I would refer back to the guidelines when you are talking about ranges for blood pressure goal, because this is one that we need to keep somewhat tight and in a range, not less than or greater, less than, because you're right. If it's 100, we're going to start harming patients. We also don't want it peaking either. So I would just say go back to the guidelines, but you should be able to have a range in your blood pressure parameters. That's all I want to add.
Thank you. Yeah, absolutely. I love this networking. I see people exchanging emails. I love it. Yes.
Hi, I'm Shannon. I'm a nurse practitioner for neurology and part of the stroke team. My background is CVICU and neuro ICU, so I have a lot of bad habits of the intensive care nurse.
More from the CV side than the neuro side, I'm just saying.
Well, probably. So, first of all, our stroke team, because I'm usually team leader, does not leave for ICHs. We stick around until the patient is actually, I usually stay until the patient is stabilized no matter what we're doing. But I wanted to refer back to our little gal who's 75 years old that came in with a blood pressure of 140/90. I know the guidelines didn't say to do the CTA, but I actually would lean towards adding a CTA to her workup because her blood pressure wasn't super high. And, why is she having a lobar hemorrhage with a blood pressure that is, pretty much within guidelines? And then, look for another potential possibility of something else that might be going on upstairs.
Yeah.
And then I also have a comment about the ranges.
Love
I collaborate with, I call them the boys because I'm the only woman. And if I ask one of the boys a question about what range they would like for our patients, there's 5 of them, and I would probably get 13 different answers. So there really is no clear cut, and that's probably why they're a little bit more not willing to give a range. I'm asked for ranges all the time, and being a nurse by background, I always give the nurses a range. And then, I will come back and check on the person multiple times during the day to see how we're doing with that, or at least check remotely to see how they're doing and see if I need to buzz over there and make some changes. And for your nicardipine drip, I too, the gentleman that just said about I'll use a one-time labetalol dose. And typically I do that more so I want to treat the blood pressure now. And while they run to the Pyxis or Omnicell or whatever it is, the device that your facility uses, while they go get the nicardipine and then take, the forever amount of minutes that it takes to prime the tubing with all of those, new pumps that we're using these days, at least their blood pressure is down. I like to get it down and then keep it down with the drip. And even if I have to just use it for a short period of time, I'll do that just because their outcomes are better, and those are the current guidelines. So
I love it.
You're welcome.
I love it. I think all doctors should be nurses first. Any other questions?
Yes.
Yes, sorry.
So my question is a little bit of a question, but also just a comment. So as you were going over the guidelines, I noticed that on page 19, under nursing care, it doesn't quite highlight what the nurse's role, whether in the ED, ICU, post or prior to interventions, what the guideline is for those neurological assessments. So we always focus on those ischemic strokes, and we know it's Q15 and you need to have X, Y, and Z before giving TNK, and then after TNK you we have it all memorized.
Yes.
But there aren't quite as good of guidelines for bleeds. Have you found anything in your current practice, or what do you do? What sort of guidelines then do you base it on? Because then now our responsibility, as whether it's providers or policymakers in our hospitals, is then to then go back to the nurse and say, I know you're managing the blood pressure, managing the temperature, giving, medications, taking the pants off, and or in case they go to surgery, et cetera, and then do the neuro assessments. So I noticed that on here it just says GCS as well as other ones. So maybe just some guidance from anyone.
So what we did is we mirrored our ischemic stroke non-thrombolytic cadence. So we do Q15 for 1 hour, and then hourly until we have admission orders. And I would also follow your ESI parameters. Whatever your ESI level is, that will help guide your vital signs, and I would just throw neural checks right in there with it.
Okay. If I may ask a follow-up question, do your neuro assessments then just include the GCS and like an NIH, or is it something completely different, like checking pupils or?
We have our own, we call it the brief neuro check, but it's kind of like a modified NIH that generates a score for the nurse, and that helps the nurse know that if it's greater than 4, if it's increased by 4, I need to call the doctor. If it's only increased by 1, I'm okay, I can monitor. So we have our own homegrown that really monitors or really follows along with a modified neuro IH, or modified NIH, sorry.
That's fair. Thank you.
You're welcome. And I'm being told to stop. Jeannie's yelling.
We can take one more.
Oh, one more question. Sorry.
No, I was just going to comment that for hemorrhagic stroke, we implemented GCS in addition.
Okay.
Because the guidelines say for the hemorrhagic stroke, it's more likely to see neurological deterioration with GCS rather than NIH. So we kept our same frequent neurological assessments, but for hemorrhagic stroke, make sure to do GCS
I like
on
that.
top of it.
Nice, thank you.
Yeah.